Okay. Welcome, Jeremy. Thank you for joining us today to talk about the work that you and your team have been doing on the HemOnc.org resource. It's certainly a pleasure to have you. I think that today's discussion it's primarily all for you and your team. So feel free to share your screen and jump in as soon as you're ready, and then we'll have some time for Q&A at the end.
Great, thanks so much for inviting us. And I was trying to track down when the last time we actually presented to VICC was, and I couldn't quite get the date, but it wasn't as long ago as 2019, I hope. But that's one I found that we did present back then, but surely we've presented since then. But anyway, so we will hopefully not be repetitive. We have I think a lot of new things to share with you. But it's a little repetitive, so I warn you ahead of time. Let's see. Let me just, sorry, I get the right screen open here. Did I get the wrong screen open? In fact, I think I just did open the wrong screen. Let's see. Two presentations up at once. Let me get rid of that one. All right. We can do this. There. Okay, are you seeing full screen mode?
Yes, we are.
All right, awesome. So I'm going to I'm going to talk about the website, and I'm going to talk about the knowledge base, really become more and more of the products these days. And with that, my title at HemOnc has changed. I'm now the Chief Technology Officer. And also, of course, since I last presented here, I've moved institutions, as have others of us, of course. So I moved to Brown just about 2 years ago. And I need to hide this. Oops, that was the opposite of hiding. Sorry. Well, that made it worse. Now all I can see are your faces. I can't see anything else. Let's see. Do you still see my screen share?
We do. We see an acknowledgement slide.
Oh, great. Okay, yeah. So I'm done. No, just kidding. So I like to go in reverse. Because I have a lot of people to acknowledge, and the specific thing I want to call out on this slide are the purple names and the purple grant, which is our recent funding from the DRKB initiative at NCI and NIH. So that stands for Data Repositories and Knowledge Bases. And I didn't realize this, but I found out that we were the first such effort funded through NCI. There's a bunch of other very well-known efforts through the other institutes like human phenotype ontology and gene ontology and so forth that are also supported through this mechanism. But we're fortunate to receive that grant about a year ago. So an overview of what is HemOnc.org, for those of you maybe not familiar, this is our kind of mission statement. We're a knowledge base that aims to capture all standard of care systemic anti-cancer treatment. And as you can see from the graph here, depending on when we presented to you, we've continued to grow the content more or less linearly on the website. We now have over 1,000 content pages, of which over 300 are disease specific. We have over 1 million lines of content throughout this database. Our mission is to primarily provide evidence-based treatment type of information. And so this is extensively referenced. We have over 7,000 references and nearly 5,000 context-specific regimens. We have a large editorial board, and we've gotten up to about 1.5 million page views per year as of our recent Google Analytics. This is kind of our global reach. I like to show this slide because it basically shows more or less that every country and territory on Earth has visited HemOnc.org at least once. Some many more than that. We have about 30,000 unique visitors per month, of which about 2/3 are coming from the United States, but a good 1/3 are coming from outside, and we're trying to grow that international presence. We've also grown our collaborations, and so you see some names and logos of companies here that we've been working with over the past several years. So I said our mission, right? Systemic anti-cancer treatment. What is it? I think you all probably know, but basically, just to get us all on the same page here, anti-cancer treatments are usually given in some kind of complex combination of drugs, supportive medications, and protocols. And the details really matter. And so, our field has a low therapeutic index. Almost every drug does. So efficacy and toxicity are dependent on all kinds of details, such as how drugs are combined, the dosing, cycle lengths, and so forth. So this is one of those situations where you need to get really granular. And because of that, I think regimens have not been well represented in current systems. And this has been an ongoing unmet need for data representation. When we got started back in 2012, this was the state of the art, which were these kind of handbooks, which were these printed, brief, overviews of dosing and maybe indication for various regimens, but not much more information. Here's another handbook from 2005 that shows at least groupings under disease type. So in this case, you're seeing 3 regimens for adenocarcinoma of unknown primary. By the way, this was the only 3 and all 3 that were provided in this book. There's actually many more than 3 choices. And furthermore, some issues with these books is that the references they would provide would actually not be for the disease that it was being recommended. So, for example, one of these regimens is something that was evaluated in small cell lung cancer, or non-small cell, I should say, but then it's being advised to use in adenocarcinoma of unknown primary. So there's this disjoint there in terms of the evidence and the indication. And also a lot of drugs are provided with these huge ranges of dose. So what we've been doing over now 12 years and 12 plus years is taking the content of these books, other sources, increasingly what's on the internet, obviously, and representing the practice changing and the standard of care on HemOnc.org. And then furthermore, taking that content and transforming it into a data model for downstream applications. So just to really quickly go over what's on HemOnc.org, I kind of divide into 3 big chunks. We've got guidelines, drug information, and regimen information. As far as guidelines, we've actually really grown this over the past couple years, and Sandeep's going to talk about this more, so I'm going to just move on. We have drug information that appears to be, by the way, this is a wiki format. You probably recognize that from Wikipedia, but it's presented in a very common structure such that only the green boxed items are sort of non-standardized or non-structured. So nearly everything you would see here is structured. Same thing with our regimens. So here is a screenshot from a regimen that would be used in breast cancer. We have reference information, some information about efficacy, comparisons to other arms in these randomized controlled trials, and the dosing and so forth. And on this particular screenshot, only this part, the orange part, is non-standardized. And of course, maybe that gives you all a sinking feeling because that's the part you care about. So we'll talk about that a little bit more. But basically everything else here is in a standard structure across every regimen, every such regimen in the website, which makes extracting and transforming pretty straightforward. So that's what we've been doing for the past 5 years or so, is really growing our ontology and taking that content on the wiki and structuring it up. And so I'm sure most or all of you are familiar with what is an ontology, but in case you're not, this is just a slide from a tutorial called the pizza ontology, which is kind of a popular way to get into this area. So an ontology is basically a shared understanding or conceptualization that uses a formal and explicit specification. And that specification is basically what is in the basic format is something called a triple. It's a relationship between 2 concepts, and that's kind of how you build an ontology. So as far as our ontology, we now have 154 what we call canonical triples as of now, and these are classes of things that are related to other classes. So if you see on this table on the left, you have that sort of generic relationship. So like a component such as a drug has a brand name, and the brand name is a class called brand name. And then you can see on the right, the example, erlotinib has brand name Tarceva, and so on. I want to emphasize that this is what you would consider highly constrained. If you look at the number of classes and relationships we have, you could have 95,832 different possible triples. Only 154 of those are allowed, so a very small portion of the possible space is allowed in the ontology, and that's what really nails down the constraints on the definition. We've worked since I would say 2017, I want to say, with Odyssey. Let's just say we've worked with pre-pandemic. Okay, we started working with Odyssey. Maybe that's how I should phrase things. Pre, during, and post. And Odyssey's Observational Health Data Sciences and Informatics group. They're an international group that is working towards, I think, much like VICC, towards common representations. And as I'm looking at this, and Alex, I just reviewed our paper that we published a couple of years back, looking at the meta knowledge base. It's kind of the same idea. Like, it's a very similar figure in that paper, right? I mean, the idea is you're taking all kinds of source systems, coming up with a common data model, a common language that you transform data into, which allows for, in this case, large scale real world data analysis and visualization of those results. So we've been working very closely with them, and basically right now HemOnc is the standard for regimens in the OMOP common data model. This is a simplified version of our regimen model. You can see, I mean, basically there's two sides of our model. One side, the orange side there, is about the what, or the definitions, the constructs. A regimen is comprised of many drugs. How is that created? In what context is it used? In what diseases is it used? And on the right side, you've got what we call the evidence base, which are the information about the clinical trials that were conducted, who conducted the trials, where were they published, when were they published, when were they conducted, all this kind of information. As of yesterday, so the 20th, we have over 100,000 valid or current concepts and over 400,000 relationships, so pretty sizable by now. Just kind of going back for a minute to the website view. So here's just another screenshot from the website. And by the way, if it gets too loud, it's getting pretty loud over here with the edge trimmers. So if that's starting to bother you, I can move inside. So just let me know. Is it okay, Alex?
Yeah, we're not picking up any of it on this end.
All right, that's my great my earbuds, I guess. Great noise canceling. All right, so all right, so now we're back at the website view, and what I want to just emphasize here is the relationship between the website and the model, which is basically as shown here. Each piece of that representation on the website is going into different pieces of the model. So that's kind of how that looks and works. Beyond the website, though, we do have additional things. So, for example, we have external mappings, which are critical, right? If you're going to speak, you try to speak the same language as an external terminology. And these are our current mappings. So we have mappings to various component terminologies, condition terminologies, and regimen. We have crossover over there, mappings over to the NCI thesaurus. Something else that we've really worked on is we call the ancillary tables. So what I just showed you so far is related to our common data model. Well, there is a complexity that's not easy to represent in OMOP. And so these are our ancillary tables. And I'm showing you not all of them, but most of them. And these fall into the domains of drugs/regimens, clinical trials, and also clinical trial lists, people who are doing the work. And you can see some numbers here for each of these tables, some of which are quite large, and some of which we believe are almost unique in their content. For instance, our indications table, which has nearly 3,000 rows, has what I think is every FDA indication in a structured way for anti-cancer drugs. It also has EMA, PMDA, NMPA, other, basically all, not all, but many different regulators. Canada, Health Canada, and we're expanding this over time to be sort of a very comprehensive and structured representation of indications, which are otherwise usually represented, as you know, in string formats by the FDA and others. Altogether, we're getting close to 1 million data points in these ancillary tables, so they are quite a substantial portion of our knowledge base. Since you're all about biomarkers and genomics, I want to talk a little bit about some work that we did just before the pandemic with Alex, which is around building out biomarker eligibility criteria information. on the wiki. And so just a kind of a refresh on this. So we have over 50 pages on the website, which are biomarker defined, like at the page level. So, these might be like a protein, like a HER2 positive gastric cancer has its own page. And it might be like a genetic thing. So EGFR mutated non-small cell lung cancer has its own page. All of those labels are integrated into the knowledge base as well. But something we started working on with VICC was study-specific eligibility criteria. So the page itself might not be specific to a biomarker, but there might be one or more regimens there that are. I just did a count. There's about 345 of those, a number of which were initially created during that edit-a-thon we had with y'all back in January 2020. But right now, these remain to be normalized and integrated into HemOnc. So you saw that screenshot before of one example of these where the string is there, but it's not exactly in a format that's ready quite yet for full integration. So backing up here to our overall content and some comparisons to other publicly available terminologies and ontologies, we think we have a lot of content basically, and we have a content over a broader domain than some of these other resources, I would say. So we don't need to dwell on it, but SNOMED, long ago I found SNOMED not to be helpful in this domain, and that hasn't really changed. But there we are, with over 6,000 regimens in the ontology currently. So what is HemOnc? What is it not? So HemOnc and HemOnc.org, HemOnc.org, the website is openly accessible, free and ad-free. It always has been, always will be. The ontology has some commercial restrictions, otherwise it is free, and I'll give a page on that in a second. We really focus on phase 3 RCTs, and we focus on efficacy because toxicity is quite difficult to capture from the published literature, but we'd love to think about how. As I mentioned, we have a large editorial board, and over time, we've been increasingly accepted as an industry standard for regimen representation. What are we not? We are not clinical decision support by the FDA definition. We do know that people use the website to make clinical decisions, but we're not necessarily in that business. We are not, and cannot be a repository for all non-randomized trials. It's too big of a space. Likewise, we don't necessarily focus on capturing everything that's out there in the investigational world. Again, a big space, and many of those drugs and treatments won't go on to approval. So we feel that that's not within scope. As I said, we're about systemic anti-cancer therapy, so we're not really about radiation or surgery, although that is changing. And we are not integrated into EMR, as I believe few knowledge bases are. So as far as radiation, just real quick, we're basically working on changing the format of our radiation data into tabular format and adding it across the website. So that's an active work in progress. HemOnc is available to you. And what's happening here? Okay, great. So so first of all, you can get a portion of HemOnc through the Odyssey Athena tool, but I will caution you that this has become outdated. We're working with them to bring in a new version, but it's now a year or two out of date. So if you are a non-commercial user and you want to just take a look at this thing, you can go to the Harvard Dataverse. There's a link here, and I'll give Alex the slides later, but you can just Google or whatever HemOnc Dataverse, and you'll get right there. It'll be the first result. We have a subset that include, that even commercial users can use, which focuses on drugs and diseases. And then for commercial users, we do negotiate to individual licenses. Now, regarding what Alex assigned me, which was to give an update. To give an update, you have to know when you last presented, and so that was like a little unclear. But so I made up the fact that we may have presented to you in May of 2021. So I wanted to emphasize what's new since then, which about 3 years ago. So first of all, maybe most importantly, we are now fully constrained. So in the early days, really until last fall, we allowed what we would call non-canonical triples into the knowledge base. So things that didn't quite fit the data model. That is no longer the case. So everything in the ontology is canonical. And furthermore, we are now tracking all additions and deprecations across all tables in the all OMOP tables, so that the backwards compatibility is hopefully guaranteed. We have grown quite a bit in size and complexity over these past 3 years. So our number of classes has not changed, although the actual classes have come in and out. So it's led to a bit more complexity of the model. The number of concepts has grown by 16%, number of relationships by 28%, and relationship types and the relationships has grown quite a bit by 71%. Those ancillary tables that I mentioned 3 years ago, many of those didn't exist or they're sort of in dev. Those are now mostly in production status. And then also really recently in the last 6 months or so, a good portion of HemOnc is now available through the NCI thesaurus. So that's a recent accomplishment. So I'm going to conclude my part and then turn it over. So basically the conclusion is that our website and our ontology are what we think are the largest publicly available resources of their kinds. That doesn't mean they're complete or comprehensive, but they're on their way, hopefully. We have a lot of use cases that we've illustrated over the years. I don't have time to go into those, but those include real-world data applications, educational purposes, supporting registries, and even social network analysis. We are holding an edit-a-thon, and we hope that you will join us either in person here in Providence, which will be hopefully nice and cool in August, although no guarantees on that. We do get humidity here, or on Zoom, and that'll be a half-day edit-a-thon. And it's really going to be focused on the guideline content, and Sandeep's going to speak more about that. Here's a link, but Sandeep will also give you a QR code in a little bit. So thank you. This will be my last slide. So now I'm going to turn it over to the team, although I'm happy to take some questions first if you'd like, or we can just go right over to everybody else's presentation, depending on what you would like. Okay, Alex, I don't hear any burning questions, so maybe I answered them all.
Well, I have some.
You too.
I'm a little concerned about, like, I don't want us to get too derailed since I know there are a few other presentations queued up. So
yeah, so why don't we do those? Why don't we go through those and then maybe hold questions towards the end? Is that, or do you want maybe one question
now? Okay, well, let me just ask this then. So I was listening to your talk. I was thinking about all of the things you mentioned. First of all, over 6,000 regimens is a huge number. That's grown dramatically since I think the last time you presented on this. So that was really cool to see. I was thinking about the work that you've been doing with OMOP and the Odyssey community, and I was wondering about, like, the notion of these, like, conceptual biomarkers and how they fit into the OMOP vocabulary, and how those might align with the ongoing efforts of the categorical variation group in GA4GH. So I was wondering, if you've been following that effort at all, and if you have any thoughts about alignment between that work and what's going on over in CatVerse.
So I've not been following that. I'd love to hear more about it, but I think that every time we bring this up with OMOP and Odyssey, they don't want to touch it, right? Like, so both they and the NCI, right? Like, nobody wants to touch this idea that we really have these biomarker-defined cancers, right? And so in that coordination of concepts, right? And so they just don't want to deal with it, and that's actually been an ongoing huge issue, right? Because, like, it's very hard. And so even to the simple question of, like, if they wanted to, so it's fairly easy using Odyssey and OMOP to get, like, okay, these are the breast cancer regimens. That's easy. But if you want, like, I just want the HER2 positive breast cancer regimens, that's hard. That's very hard in their current conceptualization. Yeah, so that's maybe the simplest example that I can give, and it sounds hopefully like this group you just mentioned is working towards that very type of problem.
Yeah, I mean, yes, I think so. So maybe what we'll do then is I'll just send you some info about it after the call, and you can check it out at your convenience. But I do think that, yeah, this issue of how do we, like, structure these concepts in a computable way and then attach them to knowledge, like the type that you guys have in HemOnc, is one of the major goals of that initiative.
Mm-hmm. Perfect. All right. So actually, what we kind of flipped, we sort of switched around the order a little bit here. So Aleenah's going to actually talk specifically about an issue we have with Odyssey and with how they want us to represent drugs. Okay, so this will be the next part here. So Aleenah, you can go ahead. And Aleenah, you're both off video and muted, so I don't know if that's a technical issue.
Hi everyone. Okay.
There are three Aleenahs here. I think there's something to do with that.
Okay. Hi everyone. I'm
Yeah.
Aleenah, and I'm a postdoc fellow. I work with Dr. Warner at CCIDS. So I'm sharing my screen, and I guess then you can see the. Okay. Yeah. Okay. So today we'll be talking about how important it is to include and integrate the precise ingredient regimen components in OMOP and RDC frameworks. And before diving into the detail, I think firstly we should discuss how an ingredient is different from a precise ingredient. So basically, an ingredient is a compound within a drug that is responsible for the therapeutic action in the body, while precise ingredient is a form of that original basic ingredient, which has a variation on a molecular level and which may or may not exert a clinical activity or a therapeutic action in the body. So, for example, we have fluoxetine as an ingredient, and fluoxetine hydrochloride is a precise ingredient. So, why do we think that precise ingredients should be considered differently and should be remapped as precise ingredients? Some drugs should be remapped as precise ingredients on OMOP and RDC. Well, because they precise ingredients, because of the fact that they have a different formulation or they have a different chemical structure, which is maybe slightly different from the basic ingredient, but they can have an absolutely different, a significantly different absorption, distribution, metabolism, and excretion properties in the body. So it's a different pharmacokinetic and a different pharmacodynamic profile. So we have these 58 drugs that were internally mapped to the precise ingredient, and out of those, 32 were then remapped as ingredients. So, which leaves us with 21 drugs, which we think should remain as precise ingredient and shouldn't be remapped as ingredient because they are different in terms of their efficacy and toxicity profiles when compared to their ingredients. So these are our drugs of interest. These are the 21 drugs. For simplicity and for the sake of discussion, we'll divide them into some groups. So the first one is the liposomal formulations. And we know that liposomal formulation, when compared with the conventional drug form, here, these are the liposomal formulations, and this is the conventional form. So we know that liposomal formulations, there is sphingomyelin and cholesterol, there is a phospholipid bilayer. So what this does is it offers a sustained release of the active drug. So there is the drug is in the body for a longer period of time at a therapeutic level as compared to the conventional form. And because we know that the tumors have leaky vasculatures and uh, uh, bad lymphatic drainage. So these liposomal formulations tend to accumulate in the tumors, and because of better penetration into the target organs and because of better retention, better uh, better efficacy is observed in the case of liposomal formulations. So all these reasons combined, the liposomal formulations tend to have a better efficacy profile and a better toxicity profile as compared to the conventional formulations. So and again, liposomal formulations again do have do decrease the drug degradation, so there is a delayed clearance and a longer half-life. So all these reasons, when combined, they have a better efficacy profile. So we have these examples of vincristine, doxorubicin, and daunorubicin, and cytarabine, irinotecan. So all these formulations, they tend to have a better profile in terms of efficacy. And when talking about the second group, where we compare the ADCs, as the ADCs here is a precise ingredient. So here, an antibody is monoclonal antibody is conjugated to a cytotoxic drug, and it through a stable linker, and it benefits the efficacy profile because the intracellular release of the drug is very specific here in the case of ADCs. So because of this, and because of the low resistance, because ADCs tend to have lower resistance because they exploit the cell killing pathways, and because of the receptor mediated internalizations, so they have lower resistance. So this increases the efficacy profiles, and this makes it better than the monoclonal antibody alone. And then there are adverse effects which are worse with the ADCs, for example, cardiotoxicity or hepatotoxicity or peripheral neuropathy. So that's why we think that these drugs should be mapped as precise ingredients and not as ingredients, because their efficacy profiles are different, because their toxicity profiles are different. And then ADC and monoclonal antibody have been compared against each other in this trial in 2018 in patients of breast cancer, around 1,400 patients this was done on. And there was a superior primary endpoint observed in the case of ADCs, and which was disease-free survival. So it's 88% for the ADCs and 77% for the monoclonal antibodies. Again, it shows that the ADCs have a better primary endpoint, and it's superior in terms of efficacy. And then there's the third group where vipivotide and dotatate, these two are combined with lutetium, which is radioactive isotope. So tetraxetan is basically vipivotide is basically a ligand which combines with the prostate specific membrane antigens, and dotatate is basically a somatostatin analog. So when these are combined with lutetium, since lutetium is a radioactive isotope, it comes with all the side effects that are associated with the radiation exposure. So there's myelosuppression, hepatorenal toxicity, a carcinogenic risk, or infertility. But the one example I found very interesting is of paclitaxel, because here not only the nab-paclitaxel, which is we think it should be the precise ingredient, it not only has a better efficacy profile and a better toxicity profile, it has an absolutely different toxicity profile. So when we compared these two, and these two have been compared in 2005, and we see that the overall response rate and the time to tumor progression, both the endpoints were better for nab-paclitaxel, and nab-paclitaxel was found to be superior. But when coming to the adverse effects, so neutropenia and hypersensitivity reactions, they were found. There was found to be a lower risk with nab-paclitaxel, but what I find interesting is that there is an increased risk of neuropathy with nab-paclitaxel. So not only the risks, the severity of the risk, and the probability of having this adverse effect is different, but there is neuropathy, which is entirely which is entirely a new side effect and new adverse effect, which was found with nab-paclitaxel and not the simple paclitaxel. Yeah, and then there is this group where we compare the stable and the radioactive isotopes, and it's very obvious that radioactive isotopes would have a bad toxicity profile because of the radioactive um, uh, radioactive right the radiotherapy. So all the adverse effects associated with radiotherapy would be there. There would be secondary cancers, and there would be flare reactions, and there would be hematologic toxicities. So all these wouldn't be seen in the stable isotopes cases, obviously. So that's why we think that knowing the precise ingredient of a drug is crucial for assessing how it interacts within the body, and that's why we think why it's important to remap them, and to remap them accurately and categorize them accurately in OMOP and RDC frameworks. So because they have a different pharmacokinetic profiles, and they have different pharmacodynamic profiles, and when we are dealing with patients, we know that how the precise ingredients can have different dosage frequencies, and how the management of the adverse effects are different for precise ingredients. So knowing them, I think, allows for a more accurate ascertainment of real world drug exposures. So that's why we think that knowing the exact composition is really necessary for understanding the interactions of the drugs in the body. So yeah, that's why we think precise ingredients should be remapped as precise ingredients and not as ingredients in OMOP and Odyssey. So yeah, that's all.
Right.
If you have any questions or insights, feel free to ask.
Thanks, Aleenah. That's great. And we'll probably go right to Alex now, but I do want to just, for those of you not familiar with the issue here, Odyssey only works with ingredients. So what happens here is that they'll take what we provide them and they'll scrub the precise ingredient and replace it with the ingredient. So part of the caution when I mentioned that you can go to Odyssey and get parts of our knowledge base, that transformation will have taken place there. And ultimately, we're pushing against this. This is an Odyssey level, like a very high level Odyssey requirement that this happens. But I hope, I mean, I think Aleenah's done a great job in convincing you why in these particular cases, which are few but very important when you think about what patients are actually being treated with, these drugs are coming up all the time. That's why this is really important to us. Okay, Aleenah, maybe you'll stop sharing, and then Alex, it's you're up. You're going to tell them about the our browser. Yeah.
Certainly. So hi, it's nice to meet all of you. I'm Alex. I'm a clinical research assistant at the Rhode Island Hospital. And I'm just going to be giving a brief overview on the data dashboard we've developing. And our goal for this data dashboard was to make a web app that complements HemOnc.org and adds features that facilitate further data exploration. And so for those of you who've used the HemOnc.org wiki, you'll know that it contains a tremendous amount of really useful and interesting information. However, that information is usually split across many pages. And so sometimes it's hard to get the big picture just from using the wiki. And so the goal for this web app that we developed is to give end users a bird's eye view of the whole HemOnc.org knowledge base by aggregating data that is typically split between many pages. And another interesting aspect of this is when you consider how complete and how rigorous the HemOnc knowledge base is, you can think of the HemOnc Knowledge Base Explorer, in other words, our web app, as a way to survey the entire or almost the entire oncology treatment and research ecosystem. And so I think it gives you a way to answer lots of really interesting questions. And now in a bit, I'm going to segue into a live demonstration. But before I do, I just want to give a brief overview of how the app itself was designed. So it was coded using the R programming language. And the web app itself is developed using the Shiny Web Application Framework. I'll also quickly mention that there are currently two versions of the app. There's the official version that is accessible on HemOnc.org. And so you can access it from this URL, as well as this QR code here. And then in addition to the official version, there's also a development version that we use to test new features. And that's the version that I'll be demonstrating today because it has some fun features that will hopefully migrate to the official version soon. And so here's the app itself. When someone first opens up the app, they're greeted with a landing page that gives them a summary of the different tabs, and each tab contains different features. And as you can see, there's a cross-tab table tab, query trial list tab, and a temporal trends tab. In my opinion, I think that the cross-tab table tab is the most important tab because it contains the most information. And when I mentioned before that the goal was to give end users a bird's eye view of the HemOnc knowledge base, this is really the tab that does this. And so the first step is when you're using the app, this tab specifically is to choose which table you want to investigate. And by default, we have clinical trials selected. Then you choose two variables within that given table to compare. And so by default, we have clinical trial registry and disease condition selected. And what the app will then do is it will create a cross-tab table. And in this case, disease conditions are represented along the rows and clinical trial registries are represented along the columns, and the numbers in the tables represent counts. And so from this table, we can see that the HemOnc knowledge base has 122 clinical trials that evaluate treatments for acute myeloid leukemia, specifically within the clinicaltrials.gov database. And then you can see counts for other intersections between variables as well. And I also wanted to quickly mention a new feature that we're hoping to migrate to the official version soon. Currently, it's only in development version. But basically, as you can see here, there are text definitions for variables. And so what happens is if you click this cell here, you can see the arrows pointing to clinicaltrials.gov. So what we've done is we've called the Perplexity API. You could think of the Perplexity API as a mix between a search engine and a chatbot. And then the Perplexity API returns a definition for clinicaltrials.gov. And so this, you can also create definitions for other variables as well. And so the motivation here is to increase the accessibility of the information by having on-demand definitions. And then I think some variables that are particularly of interest to this group is biomarkers. And so you can see when you go to the treatment indications table, you can see that biomarkers are automatically selected as one of the variables. And so there's lots of other fun things you might be interested in comparing. So for example, you can compare biomarkers to disease condition, so on and so forth. Okay, now I'm going to transition to the Query Trial List tab. This is probably the simplest tab in the app. It's pretty much just one table, and I think it's pretty self-explanatory. It's showing the most prolific clinical trial lists within the HemOnc knowledge base when we're specifically looking at those trial lists who are authors on at least 10 phase 3 randomized clinical trial publications. And you can see we have different variables for the authors that can allow you to learn interesting things about them, such as what type of site they're affiliated with and what time range they were publishing. And last but certainly not least is one of my personal favorite tabs. It's the temporal trends tab. And I mentioned before that this is the experimental or the development version of the Shiny app. This is a feature that we have not yet migrated to the official version, but we hopefully we'll do that soon. And the motivation for creating the temporal trends tab was because we noticed a limitation when we were playing around with the cross table tab. And basically that limitation was specifically when looking at temporal variables. Because as I'm sure you know, if you're looking at temporal variables such as years, it's sometimes hard to interpret trends over time when data is presented in tabular format. Whereas on the other hand, a figure such as this one does a much better job of communicating trends over time. And so at some point in our development, we migrated all of the temporal variables from the cross-tab table tab to the temporal trends tab. And so that's what we're looking at here. Every figure in the temporal trends tab has a temporal variable on the x-axis and then some other variable on the y-axis. And so here you can see that we've chosen to look at the clinical trials table. Our x-axis here is the study start date. And then the y-axis is the clinical trial registry. And so what is this figure demonstrating? Well, it's showing us the number of publications that were the number of clinical trials that were started each year in each clinical trial registry. And we can see that the year 2008 has the most trials that were initiated. And for every year in our knowledge base, clinicaltrials.gov contains the lion's share of the trials. And so that's just a quick overview of the app and some of the features. Let me exit out of this. I'll return to this slide in case anyone wants to catch the URL to the app and play around with it on their own. And I'll also mention that there's a feature within the app to provide feedback. So once you use the app, we would really appreciate it if you'd give us your impressions and also suggest some possible ways that we can improve it. Thanks for listening.
Thanks, Alex. That was great. And sadly, we're losing Alex, but I don't know if any of you are in the Pittsburgh area, but Alex will be matriculating at the University of Pittsburgh Graduate School this fall and is an excellent student to be. So please consider reaching out and working with him. All right. And we're not going to let him go completely. He's still going to actually, fortunately, some of our projects are with Pittsburgh, so we'll get to keep working with Alex. Thanks, Alex. So now Sandeep, it's your turn.
All right, can everybody hear me loud and clear?
Yes.
And can you see the slides?
Yes.
Okay, fantastic. So today I'll be talking about the guidelines portion of HemOnc.org, which I think is highly relevant to this group. And as a quick introduction, my name is Sandeep Jain. I'm currently a HemOnc, a clinical fellow at Brown University, finishing up my second year with my third year quickly approaching, and that will be my final year in the fellowship program. And I'm currently also serving as the HemOnc.org intern for this academic year, which is wrapping up. I started my interest in computer science in middle school. My HemOnc interest started growing in college, and finally in medical school. I delved into the intersection of HemOnc and informatics, where I explored data visualization, data harmonization, EHR extraction, and ontology creation. And that's actually around the time that I was introduced to some of the ideas that are really important to VICC, like the representation of genomic information through HL7, and also the Odyssey OMOP model. And then later on in residency, I received my clinical training in internal medicine, where I also did a lot of quality improvement and patient safety work. And now finally, as a fellow here at Brown University, I'm doing a lot of work with HemOnc.org and trying to work on the guideline table, which I'll be talking today. If you ever want to contact me, Sandeep_Jain at Brown EDU. I am currently on the job market or will be pretty soon. So if any of the work that I'm working on right now or any of my skill sets you think might be useful, I'm always looking forward to connect. So looking at the VICC mission statement, it's really this third bullet point, which is what I'm going to be focusing on today. So one of VICC's goals is to develop and coordinate solutions such as promoting standardized ontologies and APIs and building a federated search function to find links between cancer gene changes and clinical actions. The important thing to understand is we're going to be talking about clinical actions. It's tightly related to clinical guidelines. Physicians around the world don't simply create new plans for their patients and new chemotherapy regimens on the spot. These are things that are very well studied through randomized controlled trials, the results of which end up formulating and helping to inform physician decisions in the clinic to help patients out. But it's not so much reading any one study. It's not just focusing on one paper per patient. It's using guidelines. Guidelines that are developed by communities and associations, organizations around the world. And so oftentimes, and a lot of you might be familiar with this already, but if we're talking about a given patient, we discuss them at a tumor board where a surgeon or medical oncologist, pathologist all get together and discuss what might be best for the patient, really forming that conversation around the clinical guidelines that are most up to date that will help inform that patient's care. And so it's really important that we take a step back and ask, who's exactly making these guidelines that all the clinicians are following, the pathologists are following, and surgeons are following for treating various types of cancer, and which institutions are really leading the force behind making these guidelines around the world. It's important kind of in parallel, a lot of work has been started. I myself have become more aware of work that's been done in the space of looking at the bias that might be present in clinical trial recruitment, where studies are being published, which populations are really being recruited, and where these authors of these trials are even from. And specifically, I'm now more interested even in like where the guideline biases might may lie. For example, like where are the institutions from the authors of these guidelines? Is it a concentrated group, or do we think it's a more well-represented population? It's hard to answer these questions about the guidelines without having a knowledge base that has compiled all this information in one spot. And unfortunately, right now, if you were to look at guidelines for cancer, they're kind of in silos. The NCCN has its own set of guidelines that are difficult to get to. ASCO has its set of guidelines, which are spread throughout the website, but actually you have to go from issue and issue, from journal to journal, to really have a good understanding of which guidelines have been updated and at what frequency and who's behind those guidelines. It takes a lot of work. The guidelines are currently in a silo format, and that needs to be addressed. And once again, more relevant to this group are the emergence of what I'm going to call here genomic guidelines. So as time goes by, it's become very obvious that genomic assays are more and more prevalent across various cancer types. I've listed a few examples here. For colorectal cancer, recommendations are being made on when patients should be getting screened and tested for certain genomic markers. In the breast cancer realms, We're talking about using genomic markers to have better risk stratification and really making clinical decisions based off of a patient's genomic markers on whether or not, for example, they should be receiving adjuvant therapy after procedures. And hematology, which is one of my personal interests, we're using genomic work a lot to determine which pathway a patient might take with a new diagnosis of leukemia. We have a very complicated risk stratification system that really is heavily reliant on genomic markers that the patients might carry at the time of diagnosis and later on. And then we're also in it's a really exciting point of topic here is talking about cancers that are actually cell of origin agnostic. So not really depending on tissue of origin, but based off of certain mutations like TRK fusions and the use of larotrectinib to help treat those patients, despite what type of tissue of origin those patients might have. And this type of information is now being incorporated into the guidelines. And this is really important to keep track of. These guidelines are being updated very, very frequently by all of these different institutions. And I think we all have this shared dream, and I think that's why we're all here today, and part of VICC and part of our HemOnc knowledge base is that there's been this shared dream that one day maybe we can build a learning system that can use a patient's variants and then using our knowledge and bringing those things together and helping to better inform precision medicine care for our patients. And the only way I see that being possible down the road is if we end up making these guidelines, putting them into a machine readable format, or at least compiling all of these guidelines together in a place that can be in a knowledge base that can be queried and searched. So we're doing really great work with guidelines now at HemOnc.org. We are now up to 1,000, and this is a little bit of an underestimate, but 1,217 guidelines that are currently on the website as of today. And this is an example of like the ASCO genetic and genomic testing guidelines that we're currently covering. So this is a little bit of the format that you might find the guidelines on the website. But what I'm doing, and part of the effort that I'm taking part in, is compiling all of these guidelines into a common table that will be openly available and searchable. And so currently we're capturing guidelines from organizations around the globe: ASCO, NCCN, ESMO, the list goes on. And I'm building tables right now for these guidelines that contain the title of the guideline, the year it was published, the author information, the institution of where these authors are from, and the guideline organization information as well. And we plan on keeping this knowledge base updated with time. So as more and more genomic guidelines are available, or cell of origin agnostic mutations are discovered, and those are incorporated into guidelines, we hope to cover that with our HemOnc.org guideline database and knowledge base. This is a huge effort. It takes a tremendous amount of workforce and power to keep something like this afloat. It's not a one and done kind of deal. We have to keep it updated. And so HemOnc.org does editathons, and we are planning on a guideline specific editathon that'll be coming August 7th of this year. It'll be hybrid and an in-person event here in Providence, Rhode Island. And the whole purpose of this is to update the guidelines currently and close guideline gaps that exist on HemOnc.org. We're going to be meeting from about 1 to 5 p.m. on August 7th, and we'll have some more well-defined tasks soon. If you think you might be interested in this effort, please go ahead and scan this QR code. It'll take you to our Google form where we're trying to take attendance and RSVPs for the event. And once again, if you have any further questions about the work that we're doing with HemOnc.org and guidelines and how it might relate to your genomic or variant work, please give me an email at Sandeep_Jane@brown.edu. I'm happy to connect, and I hope you found this talk insightful.
We have
All
time
right, Alex,
for...
we left 2 minutes for questions. Sorry, but yeah.
Exactly right. We have time for probably one question. I have one, but I'm going to hold on to it to give somebody else in the audience here an opportunity. All right, hearing nothing, I'm taking this opportunity. So, I really love that presentation, Sandeep, and the question about the effort that goes into maintaining this huge list of guidelines. You said, I think 1,217 that you guys have curated. You know, do you make any attempt to kind of associate the guidelines that you register with particular concept types or even concept groups that exist in HemOnc? Or is this more of an index of existing, you know, guidelines that you kind of just link to on an ad hoc basis?
That's a great question, Alex. And actually, as we were as we were having today's presentations, and Jeremy was going through kind of the updates on HemOnc.org, you kind of read my mind. I was actively having these same questions too on how we could make this guidelines database a little bit more useful and functional, and how it could be more interconnected to the rest of the concepts that we have on the knowledge base. And I think that's a really important effort going forward. And so what I'm imagining, and this is like the 1,000-foot view here, is that eventually what we're going to have is an interconnected knowledge base where you could look at any specific drug, a concept, regimen concept, or biomarker concept on HemOnc.org, and eventually be able to track your way to a guideline that might mention that type of biomarker or treatment regimen. And I think that would be the beginnings of really being able to form like a learning system, something that's machine readable that can actually point you to the latest guideline. I think like earlier on in my training, we're talking like years and years ago, I was so focused a little bit more on like the trial or individual study, but I'm realizing if we really want to make this an actionable an effort, it's going to have to link back to guidelines at the end of the day. Clinicians who are going to want to make decisions based off of any type of variant information are going to want to turn back and see, are there guidelines that actually take us through this space and help us navigate it? And so I'm hoping that the same way, our knowledge base will either be linking regimens or individual biomarkers eventually to the guideline or guidelines that might be most relevant. And hopefully our learning systems of the future will be making use of that interconnectedness.
That's great. So I know we're over time, but I just want to quickly add to this that ESMO, we're trying to work more closely with ESMO, and ESMO has a really nice product called the Magnitude of Clinical Benefit Scale, which you might be familiar with, the MCBS, and that is like surfacing out of their guidelines, like at the specific treatment level, right? Like they're scoring specific treatments, and those are linked into their guidelines. So we're hopefully executing a memorandum of understanding with ESMO like any day now, that we're going to make those scores available at that regimen level. And then that's a big step towards being able to tie back to the ESMO guidelines, at least. Yeah.
That's super cool. I'm going to keep an eye out for that. All right. Well, yes, we are over time. Thank you again, Jeremy and team, for coming and giving us, you know, this broad spectrum of updates from your group. Very exciting work. It's a privilege to have you here, and we look forward to working with you more in the future. Take care.
Thanks again, everybody. See ya.